assessment. A, B, C, D, E. Fourth step is transport, intensive and definitive care. And fifth step is continuing a follow-up. Then E-fast, that is now called as, instead of fast, pulmonary ultrasound is also included into this. So that is actually an extended focused assessment sonography in trauma patient. That is how you put the probe. You put the probe into the, over the liver, over the spleen, in the epigastric region, over the pancreas, over the chest and over the bladder. And you get all these clinical things if you are very unlucky and you are patient of a polytrauma. You get cardiac tamponade, right upper abdominal bleeding, left upper abdominal bleeding, pelvic bleeding, pleural bleeding, I mean bleeding from all cavities. And this is what I was talking about, liver, and this is a kidney, and you can see the free fluid. This is for a medicine, I mean internal medicine guys also. This is for our utility. We can diagnose early ascites in a patient from this or from this. From the splenorenal angle, we can see the collection over there. We can also diagnose pulmonary collection over there, right? This is the pleural bleeding, we won't go into the details. This is suprahepatic or prehepatic bleeding present over there. Blood collection, large hemoperitoneum if it is there, that can be diagnosed on this E-fast. And this is aortic aneurysm, I had never seen that. Then rush. Rush protocol is for rapid ultrasound for shock and hypotension. So rush exam sequencing is, again, you put the probe at these 9 and 10 places. First, cardiac ultrasound, parasternal long axis, apical 4 chamber, then you put an epigastric, then right upper quadrant, left upper quadrant, supraumbilicus, infraumbilicus, and then pulmonary ultrasound, right as well as left. And this will rule out almost all reasons for shock and hypotension present in this. Remember this mnemonic, that is high map, when you are talking about rush protocol for shock and hypotension. Heart, inferior vena cava, Morrison's pouch, then aorta, and last is pneumothorax if your patient is in shock. Then part 4 of today's lecture is ultrasound guided procedures. These are the procedures which one can do with ultrasound. We can go for thoracocentesis, ultrasound guided. We can go for cricothyrotomy. It's a YouTube, you have a beautiful video about cricothyrotomy. Then pericardiocentesis. You can do pericardiocentesis ultrasound guided, and you can have a vascular access ultrasound guided. Apart from the diagnostic, this is the therapeutic application. And I'm stopping over here because it's very exhaustive course which one is supposed to be doing this over a period of 4 days, basics for 2 days and advanced for 2 days. If you want this book, I am having this right now with me in my pen drive. You can get a complete book if you want, if you are interested in. General ultrasound in the critically ill patient, which is written by Lichtenstein, is a very thorough gentleman who has come during Pune conference. And this is another book which is many chapters are written by Luksha Neri, who is the pioneer behind this Win Focus group. Thank you very much. Now I think after Mahesh's lecture, we will be demonstrating it on a human volunteers about the various locations, and maybe 1 or 2 of you can try these probe placements and positions. Thank you again. Thank you very much.
Thank you, sir, for widening the spectrum of our knowledge. I would request Dr. B.D. Wag, sir, to felicitate Dr. Rajan Barokar, sir, with memento. Now I would request Dr. Sachin Bele, sir, to introduce Dr. Mahesh Fulwani, sir.
It's my pleasure to introduce Dr. Mahesh Pulwani. He is an eminent cardiologist of Vidarbha. He is director of Sri Krishna Vidyalaya Nagpur. He is director of Yotma Cardiac Center. Few of his publications: Indian Heart Journal, Can termination of AF be achieved post BMV in case of rheumatic heart disease? American Heart Journal, follow-up of 82 cases of PDA coil closure. Indian Heart Journal, Tetralogy of Fallot, BPV and experience. Clinical research training, he received certification of ICH, GCP training as well. Please, I request Dr. Mahesh Pulwani.
First of all, let me thank the organizers, Wepicon, for inviting me and allowing me to discuss with you about utility of echocardiography in ICCU. I am very much happy that I have to do investigation of only a small organ, not like Rajan Barokar, who has gone from head to toe and telling you all the pouches and all everything. It's difficult to understand and remember such a vast knowledge, but for me it's not that vast. First of all, I request you all to close your eyes. Whatever Dr. Rajan Barokar has told you, put from your pen drive into your hard drive and empty it and come over here again. Should we be focusing only on these, or are we interested only on looking at certain places of life? Should we be only looking at the good pictures, not the ugly pictures? Probably not. Echo is very useful in ICU, as Dr. Rajan has clearly given you evidences about utility of echocardiography, or for that matter ultrasound machine, in lung, in abdomen, or for vascular access, or for looking at the internal jugular vein, femoral artery. We look heart through the echocardiography machine, and for this its use is in acute chest pain situation, pulmonary thromboembolism, heart failure, acute dyspnea, patient who comes in shock or hypotension, and for me today's most important will be assessment of the hemodynamic status of the patient by using ultrasound machine. Use of echocardiography in ICCU for ischemic heart is very useful when there is especially atypical presentation of chest pain. Non-diagnostic ECG and atypical presentation. We have ECG shows ST elevation, but the patient does not give you a significant chest pain history. Or you see patient gives, okay, I had chest pain for almost 2 years back or 1 year back. That means what you are seeing probably persistent ST elevation for the years together, and you could very well say that this is an aneurysm or developed aneurysm. So when a patient comes with atypical presentation and non-diagnostic ECG with acute chest pain, your ultrasound machine or use of echo would add to your diagnosis and therapeutic decisions. More important than that is use of echocardiography for the diagnosis and prognostication and management of complications of acute myocardial infarction or ischemic heart. Mitral regurg due to papillary muscle dysfunction or papillary muscle rupture, or renal motion abnormality of a segment underlying the papillary muscle, or presence of VSD when patient comes with acute chest pain after 4 hours develops hypotension, shock, and there is a pansystolic murmur. It is either MR or a VSD, and prognosis is very bad. If patient suddenly collapses after few hours of chest pain, especially after giving thrombolysis, you must do an ultrasound immediately and look for development of ventricular free wall rupture and hence development of acute cardiac tamponade. The echocardiographic finding is presence of mild to moderate pericardial effusion. Because it's an acute tamponade, there will not be large effusion, it's only mild to moderate effusion and discrete segmental wall motion abnormality. you can be lucky to see the site of rupture and lucky to see the free flow of blood from the ventricle to the pericardium. Furthermore, complications of myocardial infarction can easily be picked up by the ultrasound machine, or echocardiography is development of aneurysm, pseudoaneurysm, or pseudoaneurysm for that matter. Right ventricular infarction, echocardiography is the diagnostic procedure of choice for right ventricular infarction, associated usually with inferior wall MI or posterior wall MI or lateral wall MI, RV hypokinesis, RV akinesis, and varying degree of right ventricular dilatation would be seen. Now a patient who comes with acute dyspnea, very useful tool is chest X-ray, ECG, AVG, clinical examination, and ultrasound. You look, as Dr. Bharogar has told, accumulation of fluid in the lungs, whether the patient has acute ischemic heart, that means acute coronary syndrome, and presence of significant renal wall motion abnormality. Pulmonary thromboembolism can be diagnosed very well on ultrasound machine by development of acute right ventricular dilatation. You can be lucky also to see hypoechoic shadow, or for that matter thrombus in the main pulmonary artery or branches of the right or left pulmonary artery. You can diagnose COPD and asthma. You can be lucky to pick up cardiac tamponade. For other causes of acute dyspnea, we have other bedside investigation modalities in the form of chest X-ray, ECG, etc., etc. Now, for the hemodynamic assessment, what we are very important for us is patients who needs fluid management. As Dr. Bharogar has given you good guidelines, I would further add to it, and patients with need to determination of intravenous fluid therapy or vasopressor therapy. Hemodynamic assessment can be invasive, that means putting in a catheter from the jugular vein into RA, RV, pulmonary artery. That is Swan-Ganz catheter, and you actually measure what is the pressure in the RA, RV, and pulmonary artery. And it can very well equally be done bedside by this machine, that is ultrasound machine, and we can actually calculate cardiac output, stroke volume, dP by dt, LA pressure, PVR, PCWP, RA pressure, RA systolic, and pulmonary diastolic pressure. And these all will definitely guide you in your patient management, which would alter the prognosis and outcome. How can we do it? How do we do it? Hemodynamics are flow volume, pressure, and resistance. I would not go in much detail of this, but what can be done bedside, over here now also I will tell you. That is flow volume, that is conservation of mass. This was told to us by Christian Doppler. What he said, any volume of fluid passing through a tube, you can calculate by ultrasound or by, for that matter, physically, by the development of some physics. And he gave us a law that flow is equal to velocity of flow into cross-sectional area of the tube. Correct? How do you do that? That is volume calculation. This is the cross-sectional area of the tube, pi r square. Very simple. And this is the velocity of flow. Multiply this and you get the volume. So volume is flow volume. How much volume is passing per second, per minute, or per hour is equal to area into the distance it has ejaculated per beat of the heart for our purpose. Correct? So this is called as VTI, and this is area. How can we do that? I'll tell you. Imagine this is left ventricle, this is aortic wall, and this is the aorta. And with each beat, some amount of blood is getting ejected into the aorta. That is called as stroke volume. Stroke volume is, this is aortic valve attachment in parasternal long axis view. So this is 2 centimeter, and this is TVI of the aortic wall in apical 5 chamber view with pulse Doppler. Correct? This is 23 centimeter. Now you make pi r square of this into 23 centimeter equal to stroke volume. If you don't want to do pi r square also, do this. Stroke volume equal to cross sectional area into TVI. So cross sectional area is pi r square into TVI. TVI can be given easily by this machine. So if you don't want to do pi r square, that is 0.785 into 2. 2 is this is 2. This distance is 2 centimeter. This has been taken from 2. 0.785 into 2 into 23 is equal to 72 is stroke volume. It is as simple as that. Multiply this with heart rate, will give you cardiac output. So Normal left ventricular systolic volume is 50 to 90. Stroke volume is equal to LVOT diameter into 0.785 into LVOT VTI is equal to stroke volume. Correct? And if you multiply this with heart rate, it gives you cardiac output. Multiply this or divide this by body surface area, gives you cardiac index. So this is very simple, and mind you, it takes 10 seconds to do it, not more than 10 seconds. You do every day, we do it every day for almost many patients, and it takes only 10 seconds. Now further into the what Dr. Barokar is telling me, physics of ultrasound, I would not go. Even today also, sometimes in a month or 2 or 3 months, I get bad dreams that I have left that chapter of physics in ultrasound during my DM days, and there is a long question in exam, physics of ultrasound, I have to leave that question. But Bernoulli you must all know. Bernoulli is 4V square. But then how Bernoulli has come, let us leave it, but final Bernoulli is 4V square. That means pressure across the chamber in a flowing blood or flowing fluid is the difference of pressure is 4V square. And how do we do that? Put in a cursor across tricuspid wall, mitral wall, VSD, and you measure the difference of pressure in one chamber and difference of pressure in another chamber. You come to know what is the pressure in another chamber. For example, in this patient who is a VSD, LV pressure is equal to aortic pressure. So aortic pressure has been written as 120, blood pressure is 120, so LV pressure is 120. This is VSD jet, say around 5. So right ventricular systolic pressure will be 120 minus 4V square of this. Right ventricular systolic pressure is 125 minus 4V square of this, that is 29. So 29 is right ventricular systolic pressure, which is normal. Correct? Echocardiography machine has been aptly called as pulmonary artery catheter in box. You can measure everything what is required to manage patient. See this, right atrial pressure. Dr. Barokar has told you clearly that if you put in a cursor over, if you put your ultrasound probe into the epigastric region and see this IVC appears a little bit full, but it collapses well in inspiration. This gives you that your patient's right atrial pressure is normal or less. Correct? This is called as IVC collapsibility index. If your IVC collapsing is more than 50%, you have good amount of chance that your RA pressure is normal. Or if your IVC is not collapsing or collapsing less than 50%, your RA pressure is slightly high, borderline higher. And if it is not collapsing at all, then it is a high RA pressure, or what we call CVP. See this? If IVC is 2 centimeters and more, and if it is collapsing less, your CVP is high. If IVC is collapsing well, if it is small in size, your CVP is low. I give you one formula, IVC 2 centimeters, collapsing less than 50%. Remember this. IVC less than 2 centimeters, collapsing more than 50%, your CVP is less. IVC up to 2 centimeters, still collapsing, your CVP is normal. IVC more than 2 centimeters, collapsing less, your CVP is high. But what is the use of these methods? What is the use of these numbers? These numbers give you whether your patient needs fluid or it does not need fluid. Is underfilled or is overfilled. We can go one step forward to measure CVP by tissue Doppler. Correct? This is tissue Doppler, blood flow velocities and wall motion. Correct? Tissue Doppler is what we are moving with pulse Doppler is velocity of blood flowing through valves, which is very high velocity. But with tissue Doppler, we measure velocity of movement of tissue of the heart, which is less in amplitude. Correct? It is less in amplitude. So this is tissue Doppler, measurement of the movement of the tissues of the heart. For example, mitral annulus and tricuspid annulus. This is, if we are talking about right side, we measure movement of the tricuspid annulus and movement of the blood flow through the tricuspid wall. So one is called as E. E is pulse Doppler assessment of the blood flow velocity through the tricuspid wall. What we commonly do, everybody doing is, that is called as, this is This is what is tissue pulse wave Doppler of the tricuspid valve. So this is E, is 50 centimeters per second. Now this is tissue Doppler of the tricuspid annulus lateral tricuspid annulus of the right ventricle tissue Doppler, and this is 6. Correct? Now divide 50 by 6. That is called as E by E prime is 8. What will come out to be? 8.8. Anything around 10 centimeters or around 6 predicts RA pressure of 10. Correct? CVP here in this patient would be around 10. So not high, not low, or normal CVP. IVC, collapsibility index, and E by E prime of the right heart gives you RA pressure. So I was saying that echocardiography machine is a pulmonary artery catheter in the box. Now I have given you RA pressure. I will move further, go to RV. Correct? If there is tricuspid regurg, you all know how to calculate RV pressure. That is 4V square of the tricuspid regurg is equal to RV systolic pressure. Simple. If there is no tricuspid regurg, then it is difficult to assess the RV systolic pressure. If there is VSD, then we can see the RV systolic pressure by the jet of the VSD. If there is TR, then by 4V square of the tricuspid regurg. But if there is neither VSD nor tricuspid regurg, then we leave this RV systolic pressure. We move forward to pulmonary artery. From here we go into the pulmonary artery. Now our catheter, Swan-Ganz catheter has entered the pulmonary artery, and this is what we get on the monitor in either in cath lab or in the ICCU. This is pulmonary artery systolic, diastolic, and mean pressure. Pulmonary artery systolic, diastolic, and mean pressure has been written over there. Now, can we measure pulmonary artery pressure in ICCU by use of echocardiography? Answer is yes. See, RV systolic pressure, if it is there, then it will be equal to pulmonary artery systolic pressure. Pulmonary artery systolic pressure is equal to RV systolic pressure. Now, if there is pulmonary regurgitation, which is usually there and 99% it is there, pulmonary regurgitation, right? This is pulmonary regurgitation. You measure, you see this pulmonary regurgitation, get a good envelope of the pulmonary regurgitation, correct? Now you measure this velocity and this, correct? So what is written over here? Assessment of right heart pressure, right ventricular systolic pressure, I told you, is tricuspid regurg, and pulmonary artery end diastolic pressure. Now I'll give you how it is done. This is pulmonary regurgitation, correct? Pulmonary regurgitation. Now you do what? What do you do? Pick up this velocity over here. Here, let us start with this velocity. Pulmonary end diastolic velocity is 0.8, probability over here is 0.8. This is pulmonary artery catheter pressure. What it says that 16 is the pulmonary artery diastolic pressure. Pulmonary artery diastolic pressure is 16. What about echocardiographic assessment of pulmonary artery diastolic pressure? See this. Pulmonary artery diastolic velocity is 0.8 and RA pressure. How do we know RA pressure? By IVC. Our IVC gives that RA pressure is around 10. If it is not full, if it is full, if it is collapsing or non-collapsing. So let us, our RA pressure is around 10 and pulmonary artery end diastolic pressure velocity is 0.8. Pulmonary artery diastolic pressure now would be by this formula, simple, 4V square. Everything in echo is Bernoulli. 4V square is 4V square of this, 4V square minus, this will be plus RA pressure is equal to 15. So pulmonary artery diastolic pressure is equal to 4V square of pulmonary artery end diastolic velocity plus RA pressure. This is pulmonary artery end diastolic pressure. If you want to know pulmonary artery mean pressure, take up this velocity. Mean pressure here it is 23. Let us see how it comes to over here. Pulmonary artery mean pressure will be 4V square of this. That was 1.4 4V square plus RA pressure is equal to 20. So we have pulmonary artery systolic pressure, pulmonary artery diastolic pressure, pulmonary artery mean pressure, right ventricular systolic pressure, right atrial pressure. Right atrial pressure is always mean. So RA mean, RV systolic, pulmonary artery systolic, pulmonary artery diastolic, and pulmonary artery mean. This is. Let us go further. Can we see LA pressure? If there is MR, if there is mitral regurg, again in ICCU or in ICU, it is very common to get mitral regurg. It is very extremely common. There will be trivial mitral regurg in many patients. Pick up that, and LA pressure is equal to systolic blood pressure minus 4V square. 4V square of the mitral regurg. Go for MR, 4V square, SBP minus 4V square is equal to LA pressure. Can we get further down, LV EDP? Of course, yes. Category. And this gives a very good indication of the pressure over there. If there is high pressure, the tissues would move less. If there is less pressure, tissues would move more. It is simple common sense that if there is more pressure in the LA or LV or RV or tricuspid or RA, the tissues would move less. If the heart is empty, the tissues would move more. So this is the principle of tissue Doppler imaging. Measure the velocity by pulse wave Doppler, and E prime is tissue velocity by tissue Doppler. And measure the ratio of this, you get one more pressure of the heart, that is called as LV filling pressure or pulmonary artery or capillary wedge pressure. That gives a very important clue for fluid challenge to the patient. E by E prime, as the LV filling pressure increases, that means what? As the patient is developing pulmonary edema, or if his left heart is failing, or if his left ventricle is failing, his pressure inside increases, the mitral E wave increases, velocity of flow across mitral wall increases, but tissue movement decreases. That means annular E prime decreases and E by E prime will increase. So if it is 10, this keeps on decreasing, this becomes 20 and this becomes 2. So it is 10. If this becomes 40 and becomes 1, it is 40. So as E by prime increases, that means your LV filling pressure is increasing, your patient is developing a state where he will develop pulmonary edema. So this is what a correlation. E by E prime correlates very well with pulmonary capillary wedge pressure. Normal pulmonary capillary wedge pressure is somewhere to the tune of around 10 or 15. 10. Anything more than 15 suggests diastolic heart failure or high pulmonary capillary wedge pressure. How do we measure that? E by E prime into 1.2 plus 2. This looks very dangerous from here, but in practice, it is a question of only 5 seconds. And very honestly, I am telling you, if you see my reports, all patients, even in OPD, we give LV EDP equal to 25, or LV EDP equal to 12, or LV EDP equal to 20. Especially if it is high. If it is normal, we may not give it also. We just write that there is some diastolic heart failure. But if I find that LV EDP is 25, I would make it a point to write that LV EDP is 25, or for that matter, pulmonary capillary wedge pressure is 25. I want to give you an indication that your patient needs more diuresis. Even if he is moving around, even if he is not an ICU patient, he is class 3 heart failure. What he needs is diuresis, increase the diuresis, increase ACE inhibitors. So this is what is the management from this E by E prime. A decrease in preload would be classically seen as low E by E prime ratio. This patient needs less of fluid, reduce the diuresis, Or if he's in ICU, increase the fluid or increase the preload by giving him more fluids. See an example. This is pulse wave Doppler across mitral valve. Both look almost nearly same, almost, I'm saying almost, they are not same. A person who has a vigilant eye would tell me that this is not